Good morning. This is Sunday, the 12th of April. It's been around 2 weeks since I last posted something. It's been a very busy time. Apologies, I meant to do something a bit sooner. Anyway, I've got three shorter YouTube videos to do this morning. The first will be this one, of course, on my personal observations of COVID-19, my direct experience with it over that period of time. The second will be looking at the issues in relation to testing, and the third will be a sort of mixture of different topics, looking at the future, looking at a very particular document published by a Dr. Paul Marek from the East Virginia Medical School in the United States, which I find fascinating, and also just looking at some of the political issues. And there was a particular article in the British Medical Journal this weekend published by Karman Abbasi in relation to the so-called scandal within the NHS, and unfortunately things have become very political, and there are a lot of reasons why that is so. Anyway, so this first session relates to my own experience. Over this past 2 weeks, there have been no deaths that I have been aware of within my professional work as a result of COVID-19. There have been 5 episodes of what I would call viral-induced pneumonitis. So that's pneumonia is a word that we're more familiar with. Pneumonitis is a little bit more specific and relates to inflammation within the lung, and that's quite important because in fact, it looks much more likely that the second week of illness that does happen in a number of people relates to, if you like, an altered immune response, that it's not directly attributable to the virus itself. It may have actually gone by then, and that it's a dysfunctional immune reaction within the lung tissue itself that causes this quite nasty inflammation within the lung. I'll come back to that. Of those 5 cases, one person was in hospital for a short period of time and is now at home recovering. Very, very tired, but she will make a full recovery, that's for sure. So once again, I think the key bulletin here is that I have had direct or indirect contact with around 100 people who have been affected by the virus, and for the vast majority this is a very unpleasant but self-limiting illness with recovery often around day 6, day 7, especially in younger people. And it is an unpleasant illness, but these people are getting better quickly, and it's very important to identify the people who are going on to develop symptoms beyond day 7, and this relates to this, if you like, altered immune response to the virus. Obviously, still making the point that there are relatively few children who have been affected by COVID-19, and it is certainly my own personal belief that this is as a result of previous exposure to normal coronavirus, which is part and parcel of our winter experience in Scotland and in many other parts of the world. Okay, as I've mentioned, there's this fascination with the transition from a self-limiting illness to one that seems to get worse around day 6, 7, 8, 9 and so on. And obviously I have had direct contact with these patients whose cough becomes worse, who become more breathless, extremely tired. These individuals are invariably over 50 years of age, and as they have maybe done with the flu in the past, they've just gone to their beds and lain still. And that may work for the flu, but it certainly doesn't work for COVID-19. So there is no doubt that just lying still in your bed, not eating, not drinking, is only making you more vulnerable to these immune complications. And it's very important that we look at issues of supporting the individual to get out of bed, walking them around the house, doing some chest breathing exercises, trying to get them to nourish themselves properly, and using build-up drinks like Fortisip or Fortijuice or Ensure, which are readily available from the pharmacist. And I think it's very important that all of these aspects of care are addressed when someone is clearly not improving by day 6, 7. It's interesting that even some of the reports from China and elsewhere on autopsy of looking at heart and lung tissue, there's been very little, if any, evidence of viral inclusions within the post-mortem report, and that what we're seeing is this aggressive inflammatory response. And I think, as I say, this is about the host reaction to the virus rather than the virus itself. And thankfully, for the vast majority of us, we will react in a normal way rather than an abnormal way. And I'll be talking about how we may be able to shift the balance in our favour. Okay, this, if you like, offers then a window of opportunity, because once we end up in hospital, there are only really two things that can happen. And thankfully, the one person that was hospitalised only needed supplemental oxygen. And although I have no direct details, it's very likely that our Prime Minister was exactly the same. There was not a prospect of needing ventilation and intubation, albeit there must have been some concerns. The problem with having mechanical ventilation is one of survival, and the figures are grim. Really, there's a 50-50 chance of living if you get that unwell. Men do worse, smokers do worse, and certainly the older you are, you do worse. And certainly those with underlying conditions such as diabetes, even more so. There may well be some ethnic factors, and that's been highlighted in some of the medical and general press. And there are a whole array of reasons why that might be the case. There may be particular genetic vulnerabilities. It may be about the practice of worship. It may be about the close-knit and large extended family units. And it may even be about body shape, pot belly, diabetes, and all of these factors. And indeed, this is important. Size and shape are important. If you're being ventilated, if you get that unwell and you have to be ventilated on your front, there's clearly a big problem trying to ventilate people lying on their belly if they've got a pot belly and pushes the diaphragm back up into the chest. And these people just don't do very well at all. So my thinking is very much, and I'm sure with many doctors around the world, is about this window of opportunity. How do we try and ameliorate that inflammatory reaction that seems to take off around the end of the second week, and try and reduce the number of people that end up needing this aggressive care, which, frankly, doesn't have a great success rate. So, I, over the years, have prescribed a drug called azithromycin under guidance from respiratory experts for a lung disease called bronchiectasis. And it made me think about how that drug works in that particular way. A lot of research has been done and nobody's quite sure how it works, but it has an immunomodulatory effect. And that's personal to me because I mentioned in the previous video I have IgA deficiency, and I was concerned that I'd be a sitting duck for COVID. And I'll go on to that later in a subsequent bulletin, but I thankfully am IgG positive, and I know that now that I had my illness in Austria skiing before Christmas. I assumed it was just another one of my lower chest infections, and that thankfully I had access to azithromycin, which is prescribed by my own NHS GP under recommendations from previous specialists. So I took azithromycin myself, and the illness, which I assumed was not COVID, just went away, and I now have IgG antibodies. Anyway, it made me think about my experience, the experience in bronchiectasis and using azithromycin as an immunomodulatory drug. So I have therefore instituted this in a small number of cases. That we're talking about 3 people who were getting worse at day 6, 7, 8. I knew that their ECG was normal, so they didn't have a prolonged QT interval, because that's a drug we shouldn't give to people who may have vulnerability to arrhythmias. And the results have been simply quite breathtaking. And it may well be that these people were going to get better anyway. I do not know, but I have shared this information with other doctors and experts in the respiratory world. And I know that these drugs are being looked at largely in the United States alongside antimalarials and so on and so forth. But there is a window of opportunity with patients who are getting worse at day 6 and day 7 when they should be getting better. And what it looks like is it's not the virus itself that's overwhelming the body, it's the body's own reaction to that that viral presence. And indeed, the person that ended up in hospital had repeated tests done and they were negative. The virus is long gone from the nasopharynx by day 8. And if it's still there at all, it may be present in the lung, but I suspect it's long gone from there too, despite the fact the patient is suffering. Okay, therefore that brings us back to this sort of general care at home. And if someone has this pneumonitis going into week 2, and we're moving them around, we're managing their fever, we're giving them fluids, we're giving them build-up drinks, getting them to do some simple breathing exercises. Some of those patients have had access to oximeters, which are the little finger clip devices that measure the oxygen level in your blood. They are ubiquitous now in hospitals. The bigger devices are very, very expensive, but nowadays you can pick up fairly cheap clips that are pretty accurate for less than £50. And certainly, if you do have access to an oximeter and do use one, do check what your normal is, because many people don't have a level of 99% even when they're perfectly well. And if I check my O2 level on a finger clip, it's usually around 95 or 96 on a good day, whereas other people measure 99. And so it's important that if you do use an oximeter, you know where you started from when you're healthy. And certainly if I know that someone's oxygen level is above 90%, they're managing at home. Even nowadays, people have access to their own blood pressure units, and knowing that their top reading is above 100, their heart rate's under 100. It's amazing how often we can keep people away from a hospital, supported at home and recovering, and maybe with the intervention of drugs like azithromycin. I can't stress how important keeping moving is, and that simply lying in bed and suffering the fever and coughing repeatedly, you are basically making things worse. And that this, if you like, immunological reaction in week 2 with the marked inflammation in your lungs causing collapse of one or other lower lobes and inflammatory exudates in other parts of the lung. We're inviting this by lying still. It's very, very important to heed that advice. As I have mentioned in the first talk, the only other point to make is that asthmatics need to be fairly smart about upregulating their doses of inhaled steroids from day 1. I haven't seen anyone with severe asthma exacerbation triggered by COVID, but it certainly upregulates asthma, and of course that puts the coughing into week 2 and beyond. And we don't want to confuse that with the pneumonitis, very, very different set of circumstances, but it's just important for asthmatics to understand their care management plan, and if not, discuss that with their own doctor, and to intervene with their preventative care really on day 1 of any viral illness that affects the upper respiratory tract. That finishes my personal observations for today. Thank you very much for listening.